Hello, I'm Dr. Adarsh Singh, third year radiology resident in Lokmanya Tilak Medical College, Sion. Today, I'll be presenting a comparative study of dark blood and bright blood phase sensitive myocardial late gadolinium enhancement in cardiac imaging. My guide is Dr. Anika Joshi, I'm professor in HOD in Department of Radiology, Lokmanya Tilak Medical College, Sion. So first, I would like to begin with the mechanism of the late gadolinium enhancement. So fibrotic tissue has decreased capillary density and increased extracellular volume, which is the end result of many cardiac pathologies. Hence, after intravenous administration of gadolinium-based contrast agent, fibrotic tissues demonstrate a prolonged washout of the contrast as they have the reduced capillary density. This prolonged retention or delayed washout causes Stevens shortening, a phenomena where the contrast agent causes the proton in the adjacent tissue to relax faster than the normal, creating a high signal intensity on the inversion recovery sequences. In the schematic diagram, you can see that in the normal myocardium, there is a bunch of capillary networks and very less extracellular matrix. However, in diseased myocardium, you have a large amount of the extracellular matrix and very few capillaries. There are various types of the late gadolinium enhancement like subendocardial, transmural, global subendocardial, subepicardial, mid-myocardial, or no late gadolinium enhancement. These are seen in various cardiac pathologies. For getting this late gadolinium enhancement in PSIR sequence, first you have to perform a dynamic contrast scan. After performing dynamic contrast scan, you have to perform a Luke Locker sequence. In the Luke Locker sequence, a single 180-degree pulse is applied and the images are required at multiple inversion times. This is often referred as a TI scout. The sequence uses multiple TI to determine the null time of the normal myocardium. So let's see a Luke Locker sequence. In this Luke Locker sequence, initially you can see the blood appears dark. That is the blood nulls first, the LV blood pool up nulls first, and later the myocardium nulls. So after performing the Luke Locker sequence, we draw an ROI on the myocardium. So we draw an ROI on the myocardium and we get a signal intensity curve. In this table, you can clearly see at the lowest signal intensity, the TI which you get, you can perform the PSIR sequence in 3 axes. So suppose you take an example, the myocardium nulls at 320. You can use this TI of 320 to perform the PSIR sequence in 3 planes, short axis, 4 chamber, and VLA with an increment of 10 seconds. This additional 10 seconds is taken as in each scan, some 10 seconds will be lost to perform the sequence. What is the problem in this sequence? The problem is that the blood is also bright, so as the contrast between the subendocardial tissue and the blood is less, and hence many pathologies are missed easily. So there is a solution for it. In our institute, we use an intermediate TI sequence. The intermediate value of TI is used to obtain the PSIR sequence in short axis. In this given example, suppose if we use 250 millisecond, it is an intermediate TI. What is the outcome? The blood is less bright in this sequence and myocardium is less dark. However, the contrast between the blood and the myocardium is better as compared to that of the usual PSIR sequence. So on the left, you have a usual PSIR sequence, and on the right, you have the new, or that is a dark blood PSIR sequence. So in this, you can clearly see the blood appears bright and the myocardium appears dark. In the right side, or in the dark blood PSIR sequence, you can see the blood is not bright, it is gray or it is dark, and the myocardium is dark, but comparatively less dark as compared to that of the usual PSIR sequence. So in the next slide, what are the aims of my study? The aims of my study is to evaluate or compare the efficacy of the dark blood versus bright blood in detecting subendocardial late gadolinium enhancement, scar burden. Additionally, the sequence also demonstrates the papillary muscle enhancement. What are my objectives? Objectives is to compare the scar burden detection, to assess the subendocardial enhancement, to evaluate the mid-myocardial enhancement, to identify the clot formation. Materials and methods are as follows. Let's go to cases. So case number 1, this is a 30-year-old female with no comorbidity, came with a chief complaint of breathlessness on exhaustion and palpitations since 3 years. So we'll go. This is the apical cavity. First, we see apex, and then there is a apical cavity. You can clearly see that there is an transmural enhancement in the anterior, septal, and inferior segments of the apical cavity. As we go up in the middle cavity, there is a transmural enhancement of the anterior anteroseptal, inferoseptal segments. And as we go further up in the basal segment, we can see there is an involvement of the anterior anteroseptal and part of inferoseptal. As when we compare this with the bright blood sequence, you can clearly see that there is a significant underestimation of the scar. In the form, there is only thinning which can be appreciated, and myocardium enhancement, subendocardial enhancement, or transmural enhancement is not very well appreciated. So I would like to conclude this slide by saying that in the bright blood sequence, there is significant underestimation of the scar burden as compared to that of the dark blood sequence. Next slide. A 57-year-old male patient came with a chief complaint of chest pain and breathlessness on exertion. So let's see. So this is the apical cavity. You can see a complete transmural enhancement involving the septal segment. This can also be seen in the bright blood, but however, it is better appreciated on the dark blood. As we go up, you can see there is a transmural enhancement involving the enteroseptals and anterior segment. This is also seen in the blood, however, seen better in the dark blood sequence. As we go further up in the basal part, you can see now that there is a subendocardial enhancement involving 25 to 50% of the myocardium. However, this is not very well appreciated in the bright blood sequence. Hence, I would conclude By saying this, subendocardial enhancement can be easily missed in the bright blood sequence, or it can be also stated as it is better detected on the dark blood sequence. Next, this is case 3, 52-year-old male patient, known hypertensive and diabetic, came with the chief complaint of chest pain associated with swelling in bilateral lower limb. This is the apical cavity, this is the middle cavity, So now you can see clearly that there is a subendocardial enhancement involving 25 to 50% of the myocardium seen in the dark blood sequence, which is not well appreciated on the bright blood sequence. Also, there is a focal transmural enhancement involving the inferolateral segment in the middle cavity, which is also seen in the bright blood but better appreciated on the dark blood sequence. So again, I would like to state the statement that subendocardial enhancement and scar burden is better detected in the dark blood sequence. Case 4. In this case, you can see that there is subendocardial enhancement, which is very well seen in the dark blood sequence and not appreciated on the dark blood sequence. In the case 5, you can see that there is a papillary muscle enhancement, which is seen very well in the dark blood sequence and not appreciated on the bright blood sequence. So even though papillary muscle enhancement is not very significant, its detection is only possible in the bright blood sequence. What are the disadvantages or drawback of this sequence? The drawbacks are, this case suggests the drawback. This is a 36-year-old patient. Asymptomatic routine 2D echo was done, revealed hypertrophic cardiomyopathy. So you can clearly see that there is a septal hypertrophy. The septal thickness was more than 15 mm. You can see that there is a subtle mid-myocardial enhancement seen in the inferoseptal part and enteroseptal part, which is also seen in the dark blood sequence, however, is better appreciated in the bright blood sequence. So for the detection of the mid-myocardial enhancement, the bright blood sequence is better, in which there is a complete nulling of the myocardium. This is a case 7, 27-year-old female with a dilated cardiomyopathy. You can see the apical cavity, which shows a hypointense structure, which is not very well seen in the bright blood sequence, and hence I can conclude this slide by saying that the clot detection is much better in the bright blood sequence as compared to that of the dark blood sequence. So I would like to conclude my study by stating that the scar burden underestimation. So the bright blood sequence significantly underestimates the scar burden, and the dark blood is way better than estimating the exact scar burden. Limitations in subendocardial and papillary muscle enhancement. The bright blood sequence struggles to detect the subendocardial enhancement and papillary tip enhancement with confidence. Clot detection. The bright blood phase sensitive due to better contrast is better in detecting the clot number and size. And the last mid-myocardial enhancement is also seen better in the bright blood sequence, as there is complete myocardial nulling. So these are my reference. Thank you.